Hi guys, we're going to look at how to start an IV and how do we make that safe for our patients. We've already talked about central lines. That central line is any IV or vascular access that ends at the superior vena cava. Today we're just going to talk about those peripheral lines. A peripheral line is started in the periphery and it only has that really short catheter. If you can remember in Concepts 1, we talked about ports and tunnels and non-tunneled central lines. We talked about PICC lines, and those are really long catheters that reach to that superior vena cava. Now we're moving way down the arm to that periphery and only using a very short catheter that will stay within that vein close to where we place it. The rules are very different when we look at peripheral IVs, so we want to look at this type really closely. So let's get started here. So before we initiate an IV, we need to understand the indications of why does our patient need this IV. Do they have a fluid and electrolyte imbalance and they need those maintenance fluids to help compensate for any losses? Do they need medications through the IV because there are not other safe routes because the patient's GI tract is destroyed, or they need a constant blood level of that medication? Other indications may be the use of TPN. These are typically given in central lines, but they can be given in those peripheral situations. Or does the patient need a blood transfusion and needs that line for that reason? What are some of the advantages and disadvantages of IV therapy? Some of the advantages might include that it's a fast-acting absorption of medication that can maintain that therapeutic level in our patient. It can be less irritating to the fatty and muscle tissue because if you're giving that medication frequently. Some of the disadvantages might include if you make an error, there's no turning back from that because that absorption does occur very quickly. Patients still can have irritated lining of that IV dependent on what's being administered, so we have to be aware that that could be a disadvantage. Failure to maintain surgical asepsis could lead to infection or septicemia, right? We're putting it right into that vein, which goes into our blood system. If the infusion is large and rapid, the patient could become overloaded very quickly. So we've already mentioned some of these types of vascular access devices, peripheral being the one we're going to really focus on. We talked about midlines, central lines, and implanted ports back in Concepts 1, and for this course we're just going to really focus on that peripheral catheter. So how do you promote your skill level and feel more confident when you're going to have to put an IV in your patient? Practice, practice, practice. We're going to practice the skill in lab this week. You may have the opportunities to practice this skill, unfortunately, on a patient. After you practice the skill, self-reflect. How did it go? What could have gone better? Make sure you're also talking with other clinicians, your peers, those with some expertise. Collaborate with them because they can give you some really great tips and pointers. Some general rules that we can talk about. We want to start with the most distal location. Subsequent attempts are going to go more proximal. So distal veins, I always ask, are you right-handed or left-handed? Because you really want to go into that non-dominant hand so it's not interfering with their activities. Use aseptic technique. Don't use some of the locations that are listed there, and I'm going to let you read through those. I mean, obviously, if they have some type of skin inflammation, rash, bruising, right, you don't want to try to poke there. If they have had a mastectomy, blood clots, infections, or fractures, you wouldn't want to use that limb either. So before we get started, here's the equipment that we're going to need. Luckily, most facilities have the same equipment in their kits. So most of the time it's going to look very familiar. You have a kit in your red bag that we're going to pull out in lab this week. And one of the first things that you need is that tourniquet. The tourniquet is used to decrease or stop the venous return of blood. So when I put this on my patient, the arterial blood can still go down. The venous blood cannot return to the heart. And so that's going to cause that vein to puff up a little bit, making it easier to start that IV. We do have to be careful because the tourniquet can also be dangerous. We don't want to leave that on too long because we are cutting off that blood supply to that arm and causing some damage to that extremity. So making sure that you are putting that on as soon as it can be released, releasing it as quickly as possible. You also have to be aware that that tourniquet can have a pinching or twisting motion. So remember, on our older adults, they have that really thin skin. So making sure you aren't tearing their skin or bruising their skin. Maybe you're putting, if they have a short sleeve, you're putting the sleeve under it, or you're putting a washcloth under it, or something so that we can have that protective barrier when we're thinking about that elderly kind of thinner skin. We need the IV catheter, which in reality is a metal needle within a plastic sheath over the top of it. We need clean gloves. Even though this is a pretty sterile procedure, we do use clean gloves because we're never going to touch the sterile area that we've cleaned on the patient's skin. And all the other equipment listed here is what you could potentially or possibly need to place that IV for your patient. Make sure you gather all the equipment you're going to need for that patient. The only other equipment that might not be listed here are some saline flushes. We're going to need to saline flush that to check the IV for any patency. So let's look at the IV catheter and try to break it down. The first thing you want to think about is the size of the catheter. Each size is going to have a different color. In my world, they are pink, green, and blue. Blue is typically what we do see with our 22 gauge catheters. You aren't going to know what size you need until you look at your patient. So it's always a good idea to take a couple of different sizes into your patient's room so that you have that available for you. So you're going to go into your patient's room that needs the IV. You're going to place that tourniquet on. You're going to look at those vessels and you're going to think, this is a really great spot to start this IV. Make sure you check the patient, look at their entire arm, look at their hands, and maybe the only ones you see are very small veins in those hands. Those little ones aren't going to be able to tolerate a really large size IV. So maybe you can see it well, you can feel it well, but it's a small one, so making sure you get the appropriate size IV. Maybe we have a really young 18-year-old patient that was involved in a car accident and they're losing a massive amount of blood. We need to dump fluids in them very quickly. So in this case, we need a larger gauged needle or larger gauged catheter. So we're going to look for that 18 gauge catheter so that it can tolerate those fluids going into our patient very quickly. So we've decided on the size based on our patient's condition. If they need fluids fast, we're going to use a larger gauge needle. If they don't, we would consider smaller gauges. Then we're going to look at our patient. Will I put it in their hand where they have smaller vessels? I'll use a smaller catheter versus looking at their AC where they have larger vessels and can use a larger catheter. Now we need to look at see what we're transfusing. If I need to give blood transfusion, this is a very viscous or thick fluid that's going to go in. So I'm going to need a larger gauge needle for that. If I'm just giving normal saline, a smaller gauge might be more sufficient. So we choose our patient's needle size based on our patient's condition, the medication, and the infusion rate. You can also see that these are safety needles. So as soon as you start that IV, there's a retraction device that allows that needle to never be exposed to you or the patient. If you look at that picture there, you can see the button that you push that activates that safety device. This allows that needle to retract, just leaving the catheter in your patient. The other part of this IV that I want you to take note is the flashback chamber. Once you place your IV, you insert it properly into your patient's vein, you will see a flash of blood in that flashback chamber. Due to the negative pressure in the chamber, this is when you know you have placed it correctly. You get blood return into that chamber, then you can activate that safety device. The activation device may look different depending on your hospital facility, so just make sure you're familiar with your IV supplies and how the ones you're going to be working with work. Each IV has a catheter, the hub, a flash chamber, and a retractive device, but each facilities may look a little different, so just make sure you're familiar with the supplies you're using. So this slide just shows you the different colors I was talking about, and each color is going to represent a different gauge size, and you can see those there. The 14 gauge is going to be for your really fast fluids, blood volumes, those really thicker, viscous fluids that have to be run, versus your little 24 gauge, which might be like a hand placement on a tiny little baby. So I like this slide because it really breaks down the size of the needle and just how much fluid it can tolerate. The only thing to consider again is that viscosity or thickness of the fluid or medication that could alter this just a little bit here. One of our biggest things that we don't want to do is get stuck. Needle sticks are very preventable, so we need to make sure we prevent them. One of the ways we can do this is to just be familiar with the equipment that we have. If you have one that doesn't retract the needle, so making sure if you set it down, there's no risk of a stick. So before you start, take note to look at the catheter, understand, be familiar with the equipment. Remember, we never want to leave an exposed needle. Maybe I'm beginning to stick my patient, something happens, and I want to set my needle down. We never leave that exposed needle. I would need to cover that needle back up, and then remember, and we'll talk about this in lab, we always scoop it back into the cap to cover it safely. We typically always use a needleless system. That's what these IVs are that we're putting in. They're called that because once we poke our patient, we pull that needle out and just leave the catheter in place. So we don't have to just keep sticking them every time. Everything else will be attached to that system. So when we talk about this system, you can see this extension tubing. It's that white portion on the left picture. Everything that we want to administer is going to attach to that, to the lure lock system. Meds, fluids, they can all screw into that lure lock system, so we don't have to stick our patient again. And we'll look at those really closely this week in lab. But you can see on that right picture where we've put our needle in place, and then the extension tubing is hooked to it. So we never have to access that again. We never have to access the needleless catheter again. We're going to put it through that extension tubing. Always dispose of our needles when we're done. Sharps containers are in every room, including the patient room, the hallways, the med room. So as soon as you're done with the task, you need to put that needle directly in those sharp containers. Making sure we always use the sharp containers correctly. You drop the needle in, you close it, but sometimes things can get stuck and you want to shove it down in. Never do that. Never stick your fingers down in that sharps container. You will need to dispose of that sharps container and start with a new one if it's too full. You always want to make sure you never recap a dirty needle. If the needle has been used, I will never recap it. So make sure you say that to yourself over and over again. If I've used the needle, I will never recap it. If you need to recap a clean needle, it's a one-hand scoop to prevent any undue needle sticks, and we will also practice this in lab. But remember, you never recap a dirty needle. So we need to find a good place to start our IV. We start by going to the furthest place away from the body as possible, the most distal. We start by looking at the hand. A couple of considerations with the hand. When we think about the hand, this is a high area of getting hit. Think about your patient going to the bathroom, all the risk factors and the areas in the bathroom that are hazards to bumping that IV against something. And once it gets bumped, it could no longer work again. So making sure that the hand, if you're going to use the hand, make sure it's a really good vein that you're going to use. Also remember that we want to make sure we're not restricting them from their dominant hand. If I do use the hand, there are some good veins. There are some things to worry about. You can see the bifurcation in the veins. This is where the vein splits. So you can see at the top of the basilic and cephalic vein, it splits. So if you're using a 1-inch catheter, you would need to start that catheter quite a bit lower than the vein so that it doesn't hit that bifurcation. And then that valve's going to block that those antibiotics or meds or fluids from going any further into that catheter. So we just need to be careful that we don't hit that split. So I would encourage you to take your tourniquet, and we'll do this actually in class, and we're going to practice just putting that tourniquet on each other, just so we can kind of get the practice of that. If we don't pick the hand, then we're going to go up towards the head of the arm. We avoid the 2-inch space right above the hand. This area is off limits because there's so many nerves in that area. And if you accidentally hit a nerve, you could cause numbness and tingling into those fingers. So the next area is the forearm. This is a great area with lots of good choices. As we keep moving up the arm, we get to that AC area, and then we worry about the patient bending their arm and occluding that IV. So again, non-dominant would be better. We might need to put an arm board on them just as a reminder to not bend that arm. But also see there are some bifurcation areas there too. So let's think about all those sterile things that we need to do. The top picture shows you the IV tubing with that lower lock system. Every time we access it, we want to scrub it at least 30 seconds before you attach anything to it. So we'll talk about scrubbing the hub, and that's what I mean. We're going to scrub that hub for 30 seconds before we attach anything to it. On my patient's arm, we want to check that the site, every time we access it, we want to check that site, making sure there's no signs of infection, which could include redness, swelling, edema, or any other signs of phlebitis, which is streaking up that vein. So this picture is just a little bit better about what we're talking, shows a little bit better about what we're talking about, all the things that can cause risk. So if we start at the bottom, contamination during insertion, anything you do from not scrubbing the site to touching the site after scrubbing it to not wearing gloves or even tearing. Sometimes you'll see older nurses tear that finger out of the glove for better access. That's really just contaminating your site. So if you contaminate your site, you put your needle in, you have a contaminated needle, and now you've just put that contamination into your patient. We also want to make sure we're not spreading any contaminants into the bloodstream. Contaminated fluid is the next one. That might be using a syringe twice. Once it's used, it needs to be discarded. The hub itself is also a site for contamination. If we don't scrub that hub for at least 30 seconds, that increases the risk of infection. The medical personnel's hands are also another contamination site. If I don't wear gloves, I need to do hand hygiene. I need to wear gloves every time that I come near that IV so that I'm not introducing bacteria to my patient. And then the patient themselves is also a contamination site. Their skin is covered in bacteria, so making sure we're keeping that clean as well. There are so many ways that we can introduce bacteria, and we know that this is a really high risk. Central line and peripheral line infections are a problem, and we can do some things to prevent this by just properly taking care of those sites. The next thing is that we change these on a routine basis. A peripheral IV lasts about 72 to 96 hours. Even if we do everything correct, bacteria starts colonizing, and we talked about this in Concepts 1, about 72 hours in. And because we know this, we know that that's about the same time that we're going to need to change this IV. Your facility would also dictate when fluids, tubing, dressings all need to be changed. So being aware of those policies for your facility. Assisting your patient with their self-care activities, making sure we're still keeping that system closed. meaning there's no new bacteria that's able to enter, is ideal. So when your patient asks you to discontinue the fluids to take a shower, you need to tell them no and explain why it's not safe to keep disconnecting and reconnecting at that site. We also need to help them if we do put an IV in a joint, let's say they're AC, it's going to affect how they brush their teeth, comb their hair, go to the bathroom. So make sure you're helping with those things or being mindful to try to put it in that non-dominant hand. If you don't have to place it in a dominant hand, then try to not place it there. Other complications listed are risks of IV placement, and we're going to get to those a little bit here shortly. Some other rules of thumb after the IV line has been initiated. So we've started the IV, we want to make it safe. How do we do that? We don't stop any continuous infusions. If your patient has been ordered normal saline to run 100 mils an hour, we don't want to interrupt that. Let that keep running. Occasionally the IV pump may alarm off because the patient's bent their arm or something has occluded it. We need to address that. If we don't and it's not infusing, then blood's going to back up into that catheter and it's going to coagulate and the IV is going to go bad. So make sure we don't stop the infusion if it's continuous and that alarm goes off, that we're addressing it quickly. So don't let that blood back up in the line. We've talked about this, making sure we address the IV if it's not being infused. Do not let clots at the tip of the needle. What this means is the IV is not connected to anything, and these are called saline-locked IVs. This is an expected thing to occur. To prevent this from happening, we're going to flush those IVs on a regular scheduled basis. Depending on your hospital facility, it may be flushed every 4 to 6 hours, but you should never let it go without flushing more than 8 hours. And that's going to keep those clots from forming at the tip of the catheter. Don't let the client manipulate the IV, especially the IV pump. And this can be a tendency. If the pump is beeping frequently, the nurses tend to show the patients how to make that beeping stop. You should never have the patient manipulate the pump or push any buttons without calling you to notify you that it was beeping. Do not put the dressing on too tight. This could allow a tourniquet effect, and then monitor the dressing so that you're making sure you don't see any signs of infection or infiltration quickly. So putting that dressing on not too tight, but not too loose as well. And then don't forget to monitor the site frequently. If you start seeing signs of infection or infiltration, then you need to get that IV out quickly. So let's move into administering some medications through our IV. We've started the IV, we have it saline locked, now we need to administer medications through it. This can happen in a couple of different ways. First, we can administer it through a continuous infusion. This is where you have a large volume one of those really big 1,000 ml bags. You attach it to your IV and it's running all the time, both day and night. We can also give it as a secondary administration, which is just a smaller volume, maybe a small bag, either 100 or 200 mils that you're going to give every 6 to 8 hours. Most commonly, that's going to be like an antibiotic. Or we can give it as a bolus. This is when we pull the medication up into a syringe. I give it as a push. You push this in at a very prescribed or specific rate. And this is usually a very small volume of medication. When we're considering running a large volume of medication, those large bags that are running the infusion continuous, we put it through the pump. We have referred to the pump throughout this lecture, and here's how we can really look at those pumps a lot closer. Why do we use a pump? It just helps control the infusion. If you work in the emergency department, you may run fluids by gravity, especially if those patients that come in have lost a lot of fluid volume and they need those fluids quickly. But most nurses that work on the floor will utilize a pump to help control the rate of the infusion. The pump helps control that rate because the nurse programs the volume into the pump and the pump regulates that volume. If the pump alarms, this is signaling that something is wrong. It could be an occlusion, meaning the patient's not receiving the fluids needed. It could be that the fluid bag has run out or low, or the patient is still not receiving the fluids. The pump does not replace the nurse. The nurse is still accountable for the IV site and monitoring it for complications or problems. And you can see pictured here is a plum pump, and these are big in just the Kansas City area. This is the Alaris pump. It's also another big one that you'll find or see a lot in your nursing career. Both of these pumps are smart pumps. The idea of a smart pump means it will check your medication, it will verify compatibility, which we'll talk about shortly. If you're going to run multiple medications and you program them into the pump, it'll check your rate, make sure that it's correct, and the multiple items, and that if there are multiple items, they're compatible. So it's really a double check so that you're following the rules and keeping your patient safe. The other thing I want you to be familiar with is if it is running on the pump, we're calculating that per hour. If we're running our fluids by gravity, we're going to count each drip per minute and then set that rate per minute to know how much fluid we are administering. So the pump is per hour, the drip is per minute. Other types of pumps that you might see are our PCA, or our patient-controlled analgesia. This is delivering pain medication. It's controlled by the patient. Again, it is still a smart pump. You can set it so the patient's not just pushing the button. Maybe the patient can push it every 2 minutes or every 5 minutes, or however you set it. And then the last one, there is a continuous epidural analgesia, and that's where the catheter is placed in the epidural space. So let's look at a secondary medication. We've talked about the primary one that runs all the time. Sometimes we need to add additional medication. Maybe I have a normal saline running all the time, but now the physician has ordered an antibiotic. I would hang this as a secondary or a piggyback for a short period of time, usually 30 minutes to an hour. The equipment for this would be the medication bag or syringe spiked into our primary infusion. When you attach your secondary bag to the pump, you prime the tubing, you connect it to the first Y port. You can see set the pump to administer the secondary medication, and then when it completes, it will revert back to the primary solution. Remember, we don't want to discontinue our fluids, then blood's going to back up, coagulate, and make that IV go bad. This slide just explains how we would administer a secondary via gravity. I'm not going to get too much into this, but I want you to be just aware of that this is also a process. One of the big things that we need to pay attention to when we're running a secondary medication is compatibility. Compatibility is all about what's going to happen when those fluids touch each other inside that tubing. By the time the medication gets to the blood, it's dispersed and it's gone. But if it touches inside the IV line, it isn't compatible with the medication, it could cause precipitate to form. So meaning those two medications mixed together could have a chemical reaction and could crystallize. And then those small crystals that form inside the line could be administered to the patient, and that could be very dangerous. So before giving medications, you should always stop and think, is this compatible? This picture can indicate what may be hanging in our patient's room. The big bag is the normal saline. Remember, that's our primary solution. The small bag or secondary infusion, even piggyback infusion. Let's say it's cefazolin, which is an antibiotic that was ordered. You can see the two will come together at that Y port. We need to make sure that they are compatible with each other. If they aren't, they're going to cause a problem for our patient. So we would not want to infuse them at the same time. So this is where your resources, Lippincott, look up the medication, pause, and then just make sure that those medications are compatible. So I would encourage you to pause the video here. Can you run normal saline and cefazolin at the same time? Are they compatible, or are they going to cause a problem for our patient? The other time we need to check compatibility is with our IV push meds or our bolus medications. When we give a bolus medication, there's a few things that we need. We need a syringe with the medication. So let's say we're giving fentanyl 50 mics per mil. When we give a bolus, we need to be so careful because this one is risky. It's going into the patient the fastest, and there's no way to take it back once it's been administered. Other things that I'm going to need are some saline flushes, at least 2, because we're going to flush before the med and after the med. So we're going to walk into our patient's room. We've checked it for any compatibilities. If we need to, we'll stop the infusion if it's not compatible. We've also looked to see how slow we need to push our medication in order to not cause harm to our patient. So we're going to stop, let's say they're not compatible. We're going to stop our primary infusion. We're going to scrub that hub for 30 seconds. We're going to flush our line with normal saline to clear out our tubing. As we flush, we're looking at our IV site for swelling, discomfort from the patient, and then we're going to administer that medication based on the specified time interval per our manufacturer. Then we're going to flush that line again at the same rate that we administered the medication. Understand that. We're going to give our medication at a specified time, and we're going to flush the line at the same rate that we administer the medication to clear the line. Again, we're going to ask our patient about any discomfort as we're pushing our med. We're going to check the site for redness or swelling. And we're going to just make sure that our patient is doing okay after the medication administration. Once it's done, we can hook back our primary infusion and get that going again. If your patient has a saline lock, the IV push medication process is very similar to that of an infusing one. We're going to flush the line, make sure it's patent, make sure we clear any clots that are starting to form. We're going to push our med at the rate that it says we can push it, and then we're going to flush at the rate we pushed our med. And then we're going to remove our syringe, and then we're going to be done, making sure we're checking our patient every time we do this. When we administer injections through our IV, we want to look at this risk. The first one says we're going to run them through an existing line or a saline lock. That small tip hanging out of our saline lock, most patients have these, are good for about 72 to 96 hours. The advantage of these is absorption rate is much faster, so our patient needs pain medication either from just returning from surgery or maybe they were involved in some type of trauma. So we need to give them pain medication, and this is the fastest way to make it absorb. The other thought is if our patient is seizing, we might need to give medication that quickly absorbs it to help stop it. We want to establish a therapeutic blood level. This is typically why we give antibiotics IV. We give these every 8 hours. On the dot, we check the blood levels and make sure they are therapeutic, and they will stay those therapeutic levels as long as we're giving those appropriately. Large volumes or continuous infusion volumes are primary medication. This is our 500 to 1,000 ml infusion that runs all the time, day and night. You can see the advantages of this type of infusion include safety, easiest method that provides stability in fluids, electrolytes, and medication. The disadvantages is that it can cause overload or imbalance. So this is why it's vital for the nurse to check on the patients hourly if they have continuous fluids running. Make sure you're checking your rate, and how long it's being run is something a nurse needs to be aware of. If you're giving 100 mils over 24 hours, that's 2,400 mils of fluid, which is appropriate for a 24-hour period of time. What if your order is 200 mils over 24 hours? That's 4,800 mils, which would be too much. So best practice is that I always make sure it's the correct concentration and dose, and that we're following the orders, preparation, and administration safely. The next one is the IV push or IV bolus. This is the one we give with a syringe. This gives a very concentrated dose of the medication directly into the circulatory system. Remember, this is a high risk, so we want to be careful that we're not giving it too fast or at the wrong rate. So maybe only giving a ml, but I want to look up how quickly that needs to be given. Typically around 1 to 3 minutes, but some medications may be 5 to 10 minutes. So making sure you're looking those up and giving them at the appropriate rate. There are advantages of this. The advantage is that it's not going to restrict the patient. I'm going to give that medication and then I'm going to walk away and they're free and not attached to something all the time, to a pole or tubing all the time. So that's an advantage. It's less restrictive, it's less time consuming, but it is the most dangerous because you can't correct any errors because it's so concentrated. So make sure you're following your rights, meaning you're doing your checks and your rights, your 3 checks, your 6 rights. We always confirm the IV location when we confirm it by attaching our flush, pulling that back to check for flash, and then flushing it for patency. If it's not in the correct location, that medication can seep into the surrounding tissues and could cause an infiltration. If the fluid is vesicant, which is could cause some bruising, redness for that patient. So this is just a recap slide. When we're doing administration, we're going to identify our patient, right? Name, date of birth. We're going to do our 6 rights and our 3 checks. We're going to educate them about the infusion. We're going to do hand hygiene, wear gloves, scrub the hub for how long? 30 seconds. We're going to flush for patency. We're going to connect the tubing to our vascular access, set the pump, observe the drip, and then document, while always observing your patient's site. All right, so let's move into some complications associated with IV therapy. What you need to understand is how to assess them, how to know if it's happening, and if you do find it, how do I take care of it if it develops? So we want to talk about prevention. How can I prevent any of these from occurring to our patient? So the first thing we're going to talk about is infiltration or extravasation. So let's look at. So when we look at infiltration versus extravasation, we know our patient has an IV. They have that IV. They're at risk that the fluid will stop flowing into the vessel and start moving into the tissue around it. And that's what happens here if they have an infiltration or an extravasation. The fluid is not running through that vessel anymore. It's running and leaking out into the tissue surrounding it. Extravasation can appear to look like an infiltration, but the difference is that extravasation is an inappropriate leakage of vesicant solution into that surrounding tissue. These drugs can cause blistering and other tissue injury that could be very severe. It could lead to tissue necrosis. Some of the meds that we can think about are our chemo drugs, Vancomycin is a big one. Vasopressors, those are all really great examples. So we've talked about infiltration and extravasation. We can also talk about fluid overload. That's where we've got some distended neck veins, increased blood pressure, maybe tachycardic, shortness of breath. We might see hear some crackles in the lungs or see some edema. With that, we're going to stop the infusion, raise the head of the bed, measure our vital signs, and probably administer some diuretics to get that fluid off. Phlebitis, to prevent phlebitis or thrombophlebitis, the big thing is we have to change that IV site. The recommendation again is to change that IV site every 72 to 96 hours. Check your facility. If your patient arrives with the IV, you should change the IV within a 24-hour period of time of arrival. We do this because we can't verify the sterility of this placement. We can't guarantee that it was placed using sterile technique. We can also do really good hand hygiene when we're caring for these, wearing gloves anytime we're touching the patient's IV, and really making sure we use that surgical asepsis or that sterile technique when we're accessing the IV so I don't give them an infection. A lot of times with the phlebitis, you're going to see redness, warmth, edema, pain streaking up from that site. If this does occur, we're going to stop the infusion immediately. We're going to remove that catheter. You can no longer use this IV because that vein is very irritated. It has some type of an infection. It may have a clot. So you need to stop, remove it, and then want to elevate the extremity to help with some of the swelling. They may need a warm compress to help reabsorb some of the fluids. If you're going to restart the infusion, just make sure you're using a completely different location. So either proximal, never distal, or a different extremity. The other thing with phlebitis that may indicate infection, you might need to collect a specimen from the site, some type of a culture, and that way we can appropriately treat if it is an infection going on. Hematoma is the next one. Hematomas are most commonly occur when you're placing the IV. So let's say I place the IV, it goes in, it looks great. But then when I'm placing the tape, I wiggle it just a little bit and it nicks the other side of the vein, or I go all the way through the vein. When that occurs, the blood leaks from the area into the surrounding tissue and it essentially makes a bruise. That's your hematoma. So what can we do for that? First of all, we can't use that IV. You've blown it, so you can't use it. You got to take it out, put another one in, either proximally or higher above the area or in a different extremity, and then just protect that arm. You can use a cool compress if the patient's complaining of any discomfort. And then let me talk a little bit more about fluid overload. Fluid overload is really nothing that's related to the IV. It just means that I may not be running the fluids at the correct rate. So it's really important for our patients when we're running our fluids that we're still really checking our heart tones, our lung sounds, looking for any edema to make sure that we're not overloading them. If they're complaining of shortness of breath, you're hearing crackles in the lungs, they have edematous extremities, we need to stop that infusion. We need to let the provider know, and we need to probably get that fluid off. The next one on the list is cellulitis. Cellulitis appears to be redness, warmth, edema, streaking in that area. We're probably looking at some potential infection. So again, if we notice these symptoms, we need to discontinue the infusion, remove the IV. Again, warm compress, just similar to phlebitis. We might need to get a culture of it, see if they need antibiotics, but that's kind of our cellulitis. And then that last one is a catheter embolus. This is when the tip of the catheter literally just pops off and is floating around in your blood vessel. So when we think about prevention of this, if it's a peripheral IV, I don't ever remove the plastic sheath from the tip of the IV and push it back. So if you feel resistant, if you don't have your needle in that sheath, you should not be manipulating that sheath. It's going to cause something to maybe pop off. Symptoms might be pain at the area, If that plastic piece starts to migrate around the patient, the pain may also move around the patient too. So when we pull the catheter, we're going to notice that tip is missing. If we notice that tip is missing, we need to send them to X-ray, potentially surgery, to remove that floating plastic piece in the body. I have actually never seen that happen, but I'm sure it does happen. So this slide again just goes over each of the prevention measures as nurses that we can take to keep our patients from getting complications because of their IVs. Nursing priorities or analysis. Remember, this is part of our nursing process. So we have a risk for fluid volume imbalance, either excess or deficient. So we're noting any fluid overload if we have excess. Risk for impaired skin integrity. There's always a risk every time we place an IV that there's going to be some skin integrity issues. And then risk for injury or fall. Remember, our patient now has a tubing and a pole attached to them everywhere they go. So that risk of fall and injury just became a little bit higher. So we've talked about several of these. The two assessments that we've talked about are you want to avoid taking a blood pressure on the same arm with that IV. When we pump up that cuff, we're essentially using a tourniquet effect, and that's going to cut off that venous supply. The other is no blood pressure on the side of a PIC, mastectomy, or stroke patient. Those are the two that if we have an IV, what do we want to make sure we're doing? Teaching the patient not to change the settings, don't pull on the tubing, how to walk with the pole if they need to get up and about to the bathroom or walk the hallways. And then this slide just walks you through how to discontinue the IV. Make sure you have an order before you discontinue it. There's nothing worse than taking an IV out because you're going to get discharge orders and the physician's like, oh, let's just give one more bolus, right? And you've already taken it out. So until you have an order to discontinue the IV, you should never take that. Don't discontinue it. Stabilize the IV catheter while you're removing on the dressing and tape. Place the sterile gauze over the site. Apply light pressure once you've removed it. Continuous pressure for that site for 2 or 3 minutes. Inspect the catheter to make sure everything's intact, and then document it. And that is the end of this video. If you have any questions, you can send me an email or we can chat about it in class. Thanks.